Hemorrhage, commonly known as bleeding, refers to the escape of blood from a blood vessel. In oral surgery, understanding hemorrhage is crucial because blood loss can quickly become life-threatening if not managed properly. Blood is vital for transporting oxygen and nutrients throughout the body, and any significant loss can lead to exsanguination, which means death from excessive bleeding. This video will provide an overview of the coagulation system, the types of hemorrhage, and the management of shock resulting from blood loss, especially in oral surgery patients. Whether the patient is healthy or has acquired or hereditary bleeding disorders, knowing how to control bleeding is essential for safe surgical outcomes. Hemorrhage following oral surgical procedures can arise from local or systemic causes. Most often, postoperative bleeding in healthy patients is due to local factors, such as injury to soft tissues or bone. Osseous bleeding may originate from nutrient canals in alveolar bone or from central vascular lesions like vascular malformations or hemangiomas. Understanding the source of bleeding is key to effective management. Local causes are usually easier to control, while systemic causes may require more comprehensive treatment. Recognizing whether the bleeding is from soft tissue or bone helps guide the appropriate intervention and ensures patient safety during and after oral surgery. The type of blood vessel involved in hemorrhage determines the characteristics of bleeding. Arterial hemorrhage is brisk, pulsatile, and bright red, often emitted as a jet with each heartbeat. Venous hemorrhage is darker and flows in an even stream, especially in the facial region where veins lack valves and have extensive communication. Capillary hemorrhage is characterized by oozing blood bluish bright red in color, and is usually not severe. It can be easily controlled by simple pressure with gauze pads. However, in coagulation disorders, capillary bleeding can be extensive. Knowing these differences helps clinicians quickly identify the source and severity of bleeding. Hemorrhage can be classified based on the timing of bleeding. Primary bleeding occurs immediately at the time of injury or surgery, as the body's hemostatic mechanisms attempt to stop the bleeding by forming a clot. Secondary bleeding happens when the wound starts to bleed again after 24 hours or several days, often due to dislodgement of the clot, secondary trauma, infection, or elevated blood pressure. Reactionary or intermediate bleeding occurs within 8 hours after primary bleeding stops, usually caused by loose foreign bodies, broken bone pieces, or extensive granulation tissue. Understanding these time-based classifications helps in anticipating and managing postoperative bleeding. Bleeding can be internal or external. Internal bleeding is concealed within body cavities such as intracranial hemorrhage and may not be immediately visible. External bleeding, on the other hand, escapes through a wound in the skin or mucosa such as epistaxis, nosebleed. Recognizing whether bleeding is internal or external is crucial for diagnosis and treatment. Internal bleeding often requires imaging and surgical intervention, while external bleeding can usually be managed with direct pressure and local measures. Both types can be serious, but external bleeding is often easier to detect and control in oral surgery settings. The severity of hemorrhage is often determined by the volume of blood lost. Mild hemorrhage involves blood loss of less than or equal to 500 ml. Moderate hemorrhage ranges from 500 to 1,000 ml, while severe hemorrhage is defined as blood loss greater than or equal to 1,000 ml. Assessing the volume of blood loss is essential for deciding the urgency of intervention and the need for transfusion or advanced management. In oral surgery, even moderate blood loss can be significant due to the confined space and potential for airway compromise. Prompt recognition and response are vital for patient safety. Spontaneous bleeding can occur without any obvious provocation, often due to decreased platelet count or hereditary coagulopathies. This type of bleeding is particularly concerning because it may indicate underlying systemic disorders. In oral surgery, spontaneous bleeding requires careful evaluation to determine the cause and appropriate management. Patients with known bleeding disorders or low platelet counts should be assessed thoroughly before any surgical intervention. Preventive measures and tailored treatment plans are essential to minimize risks and ensure successful outcomes. Hemorrhage can be classified based on the speed of blood loss. Acute hemorrhage involves massive bleeding in a short span of time, which can quickly lead to shock and requires immediate intervention. Chronic hemorrhage, on the other hand, is characterized by slow bleeding over a long period, resulting in small quantities of blood loss. Both types can have serious consequences, but acute hemorrhage is more likely to cause rapid deterioration and demands urgent attention. Chronic hemorrhage may go unnoticed until significant anemia or other complications develop. The percentage of blood loss is another important classification. Class I hemorrhage involves up to 15% blood loss, Class II is between 15–30%, Class III ranges from 30–40%, and Class IV is more than 40%. These classes help clinicians assess the severity of hemorrhage and guide treatment decisions. Higher classes indicate more severe blood loss and greater risk of shock, requiring aggressive management such as transfusion and advanced resuscitation. In oral surgery, monitoring blood loss and recognizing these classes is crucial for patient safety and effective intervention. Hemostasis is the process of stopping bleeding and involves four main steps. First, the injured blood vessel constricts to reduce blood flow, known as the vascular phase. Second, platelets adhere to the site of injury and form a platelet plug called the platelet phase. Third, the coagulation cascade is activated, leading to the formation of a fibrin clot. Finally, the clot retracts and organizes, stabilizing the wound. Understanding these steps is essential for managing bleeding in oral surgery, as each phase can be targeted with specific interventions to achieve effective hemostasis. Primary hemostasis occurs at the site of injury and is crucial for stopping blood from small venules and capillaries. Platelets release granules and aggregate to form a primary hemostatic plug. This process is rapid and provides an initial barrier to blood loss. In oral surgery, primary hemostasis is often sufficient for minor bleeding, but larger vessels require additional measures. Platelet function is essential, and any dysfunction can lead to excessive bleeding. Ensuring adequate platelet count and function is a key part of preoperative assessment. Secondary hemostasis involves the activation of coagulation factors, leading to the formation of a stable fibrin clot. This process strengthens the primary platelet plug and is essential for stopping bleeding from larger vessels. Coagulation is a continuous process, with procoagulant and anticoagulant factors maintaining a delicate balance. Injury to blood vessels shifts this balance in favor of coagulation, resulting in clot formation. Understanding secondary hemostasis is important for managing patients with bleeding disorders and for selecting appropriate interventions during oral surgery. Coagulation involves various factors, each with unique properties. For example, fibrinogen has a half-life of 1.563 days and is synthesized in the liver. Prothrombin, also produced in the liver and brain, is vitamin K dependent. Other factors such as tissue factor, calcium, and proxylurin play distinct roles in the coagulation cascade. Understanding the biosynthesis, half-life, and vitamin K dependency of these factors helps clinicians manage bleeding disorders and select appropriate therapies. This knowledge is especially important when treating patients with liver disease or vitamin K deficiency. The coagulation cascade is a complex series of reactions involving intrinsic and extrinsic pathways. The intrinsic pathway includes factors VIII, IX, XI, and XII, along with calcium and plasma proteins. The extrinsic pathway is initiated by tissue thromboplastin, forming a protease complex with factor VII and calcium, which activates factor X. The final common pathway involves the conversion of prothrombin to thrombin, which then converts fibrinogen to fibrin, stabilizing the clot. Laboratory tests such as partial thromboplastin time, PTT, and prothrombin time, PT, screen these pathways. Understanding this cascade is crucial for diagnosing and managing bleeding disorders. Hemostasis depends on several key factors: vessel wall integrity, adequate number of platelets, proper functioning of platelets, adequate levels of clotting factors, and proper function of fibrinolytic pathways. Any deficiency or dysfunction in these components can lead to abnormal bleeding. In oral surgery, ensuring these factors are optimal is essential for preventing and managing hemorrhage. Preoperative assessment should include evaluation of platelet count, clotting factor levels, and overall vascular health to minimize risks. The coagulation mechanism can be simplified into four main reactions. Reaction 1 is the intrinsic or contact phase, involving factors VIII, IX, XI, XII, calcium, and plasma proteins. Reaction 2 is the extrinsic pathway, initiated by tissue thromboplastin, factor VII, and calcium, which activates factor X. Reaction 3 involves the activation of factor X by proteases from the previous reactions. Reaction 4 is the conversion of prothrombin to thrombin in the presence of factor V, calcium, and phospholipids. Thrombin then converts fibrinogen to fibrin, stabilizing the clot. Understanding these reactions is essential for diagnosing coagulation disorders and guiding treatment. Evaluating a bleeding patient requires a coordinated history and physical examination. Key questions include personal or family history of bleeding tendency, previous surgeries or dental extractions, history of hematuria, gastrointestinal hemorrhage, easy bruising, hemarthrosis, menorrhagia, or epistaxis. Medication history and special diets should also be reviewed. Physical examination should assess for adenopathy, splenomegaly, hepatomegaly, signs of liver disease, and skin or mucosal abnormalities. Bleeding into superficial skin and soft tissues seen as petechiae or ecchymoses often indicates vessel or platelet abnormalities. Hemorrhage into joints is diagnostic of severe hereditary coagulation disorders. Most defects of hemostasis can be screened by 4 basic laboratory tests: bleeding time, platelet count, prothrombin time (PT), and partial thromboplastin time (PTT). Bleeding time measures platelet function with normal values between 2 to 8 minutes. Platelet count should be 150,000 per cum. Lower counts increase bleeding risk. PT screens the extrinsic pathway, while PTT screens the intrinsic pathway. Thrombin time measures the conversion of fibrinogen to fibrin. Together, PT and PTT also screen the common coagulation pathway. Abnormal results warrant further specific testing in consultation with a hematologist. Bleeding time is a sensitive measure of platelet function and is directly related to platelet count. Normal bleeding time is 2 to 8 minutes, and values over 10 minutes indicate increased risk of bleeding. Various methods such as IV, Duke, and template are used to measure bleeding time. The test should be performed by expert technicians, as small differences in technique can significantly affect outcomes. Bleeding time is prolonged in patients on aspirin therapy, those with thrombocytopenia, von Willebrand disease, and platelet dysfunction. Accurate measurement is essential for assessing bleeding risk before oral surgery. Normal platelet count ranges from 150,000 to 450,000 per cubic millimeter of blood. When the count drops to 50,000 per cum, bleeding occurs after severe trauma or surgery. Counts below 50,000 per cum increase the risk of spontaneous bleeding, including intracranial hemorrhage. Minor oral surgical procedures can be safely performed if platelet count is adequate, but patients with low counts may require transfusion of platelet-rich plasma. Monitoring platelet count is essential for preventing excessive bleeding during and after oral surgery. Prothrombin time, PT, screens the extrinsic limb of the coagulation pathway. Specifically, factors V, VII, and XPT is prolonged in patients on heparin or warfarin anticoagulant therapy. The test must be related to a control value, with normal PT usually less than 1 to 1.5 times the control. PT is essential for assessing bleeding risk in patients undergoing oral surgery, especially those on anticoagulant therapy. Abnormal PT values indicate the need for further evaluation and possible adjustment of medications before surgery. Partial thromboplastin time, PTT, screens the intrinsic limb of the coagulation system, including factors VIII, IX, XXI, and XII. Normal PTT is less than 40 seconds, with 25-35 seconds considered typical. PTT is prolonged in hemophiliacs and is relatively insensitive to changes in the intrinsic system. A 70% decrease in factor levels may still yield normal results, so small changes in PTT can be significant. Both PT and PTT together screen the common coagulation pathway. Abnormalities in these tests require further investigation to identify specific coagulation defects. Thrombin time measures the time required for thrombin to convert fibrinogen to fibrin, reflecting the function of the fibrinolytic pathway. Normal values range from 9 to 13 seconds. Thrombin time is useful for assessing the final step of the coagulation cascade and identifying abnormalities in fibrinogen or fibrinolysis. Both PT and PTT together screen the common pathway, and prolonged values suggest deficiencies in factors II, V, X, or vitamin K, as well as liver disease. Accurate measurement of thrombin time is important for diagnosing bleeding disorders. Local hemostasis can be achieved by mechanical, thermal, or chemical methods. Mechanical methods include applying pressure, using hemostat forceps, sutures, and ligation. Pressure counteracts hydrostatic pressure within the bleeding vessel, allowing a clot to form. Hemostat forceps are used to catch and occlude bleeding points, and sutures are used to tie off large vessels. Embolization can be performed using angiography to localize the bleeding point and deliver embolic agents. These local measures are effective for most oral surgery bleeding and are essential for safe surgical practice. Mechanical methods for achieving hemostasis include applying direct pressure, using hemostat forceps, sutures, and ligation. Pressure is applied firmly over the bleeding site with a gauze pack for at least 5 minutes, allowing a clot to form. Hemostat forceps are used to catch and occlude bleeding points, especially in small vessels. Large vessels are ligated with sutures, using non-absorbable material for arteries and absorbable material for smaller vessels. Embolization can be performed using angiography and embolic agents to selectively block bleeding vessels. These methods are fundamental for controlling hemorrhage in oral surgery. Embolization is a technique used to control bleeding by selectively blocking blood vessels. Angiography is used to localize the exact bleeding point, and embolic agents such as steel coils, polyvinyl alcohol foam, Gelfoam, silicon spheres, and methyl methacrylate are delivered via a catheter. The catheter is maneuvered into branches of the external carotid artery under fluoroscopic control. Careful mapping and superselective technique reduce the risk of stray embolic material. Embolization is especially useful for treating oral and perioral lesions with difficult-to-control bleeding. Thermal agents achieve hemostasis by denaturing proteins and coagulating tissue. Cautery uses heat transmitted from an instrument to the tissues, while electrosurgery uses induction from an alternating current source. Electrocautery is effective for small vessels but not for large ones which require ligation. Cryosurgery uses extreme cooling to induce cryogenic necrosis, especially for superficial hemangiomas. Argon beam coagulator transmits monopolar current through argon gas, allowing control of bleeding from vessels smaller than 3 m. Lasers provide bloodless surgery by coagulating small vessels during tissue cutting. Vessel ligating clips such as ligaclips are titanium clips used to permanently seal blood vessels mechanically. Applied with a clip applicator, these clips compress the vessel wall without damaging it, providing efficient and convenient vessel control during surgery. This method is often preferred over conventional tying with thread, especially for vessels that are difficult to access or require rapid control. Vessel sealing systems such as LigaSure use electrical energy and adjust current based on tissue impedance, allowing sealing and division of vessels up to 7 min diameter without ligation. Plasma coagulation and tissue management systems utilize radiofrequency energy to generate a plasma field of highly ionized particles from normal saline. These particles disrupt organic molecular bonds for tissue dissection and coagulation. The system works in bipolar mode, avoiding the risk of burns and cardiac pacemaker problems associated with monopolar mode. Tissue temperature ranges from 40-70 degrees C, sufficient for cutting and coagulation. The absence of return current enhances safety, making plasma coagulation a valuable tool in modern oral surgery. Chemical agents for local hemostasis include astringents and styptics, which precipitate proteins and help arrest bleeding. Tannic acid, silver nitrate, and ferric chloride are commonly used for minimal capillary bleeding. Bone wax is applied to bleeding from bony canals, acting by mechanical occlusion. Thrombin, applied topically, converts fibrinogen to fibrin and is gentle on tissues. Gelfoam, a gelatin sponge, absorbs blood and acts as a scaffold for fibrin network, aiding clot formation. Oxycel and Surgicel are oxidized cellulose polymers that form artificial clots and are absorbed over time. Advanced hemostatic agents include Fibrin Glue, adrenaline, microfibrillar collagen, alginic acid, natural collagen sponge, and fibrin sponge. Fibrin Glue contains fibrinogen, factor XIII, and thrombin, forming a stable clot and providing a scaffold for wound healing. Adrenaline induces vasoconstriction but must be used cautiously in patients with hypertension or cardiac disease. Microfibrillar collagen activates platelets and is absorbed in 3 months. Alginic acid forms a protective film over bleeding sites, compressing capillaries and stabilizing the clot. These agents offer targeted solutions for difficult-to-control bleeding. Bone hemostatic agents, such as ostine and calcium sulfate pellets, are used to control bleeding from bony cavities. Ostine is a water-soluble alkaline oxide copolymer, while calcium sulfate pellets mechanically block open vessels and are resorbed in 2-3 weeks. These agents are particularly useful in osteotomies larger than 710 and act as bone inductive agents. Proper application and monitoring are essential to prevent complications such as foreign body granuloma or infection. Systemic agents are used when local measures are insufficient to control hemorrhage. Whole blood transfusion may be indicated for excessive blood loss and hypovolemic shock. Fresh whole blood contains all coagulation factors but is rarely used due to component therapy availability. Platelet-rich plasma elevates platelet levels and provides continued protection. Fresh frozen plasma FFP contains all coagulation factors and is administered based on weight. Cryoprecipitate contains factor VIII, fibrinogen, factor XIII, and von Willebrand factor. Tranexamic acid and adrenochrome monosemicarbazone are systemic chemical agents with varying efficacy. Blood component therapy allows targeted treatment of specific hemostatic defects. Platelet concentrates are viable for 3 days at room temperature and must be infused quickly. 1 unit raises platelet count by 7,000 cells per cum. Fresh frozen plasma is issued in packs and contains all coagulation factors. Cryoprecipitate is derived from a single donor and contains factor VII, fibrinogen, factor XII, and von Willebrand factor. Proper typing, cross-matching, and screening for infectious diseases are essential before transfusion. Component therapy minimizes risks and provides effective management for bleeding disorders. Systemic chemical agents, such as tranexamic acid, epsilon-aminocaproic acid (EACA), adrenochrome monosemicarbazone, and ethambutylate, are used to reduce bleeding. Tranexamic acid is used for wound irrigation, while EACA and ethambutylate reduce capillary bleeding in the presence of normal platelet counts. Adrenochrome monosemicarbazone is administered before surgery to reduce bleeding risk. The efficacy of these agents varies, and their use should be tailored to individual patient needs and underlying conditions. Controlling hemorrhage from major arteries requires planned surgical intervention. Local measures are usually sufficient, but major vessels may need to be ligated if bleeding cannot be controlled. In cases of vascular tumors, hemangiomas, or arteriovenous malformations, major feeding vessels should be exposed and ligated before surgery. Visualization of the bleeding point is essential, achieved with good lighting, suction, anesthesia, and anatomical knowledge. Preparation and confidence are key to successful management of major artery hemorrhage. The greater palatine artery runs anteriorly from the greater palatine foramen in the submucosa of the hard palate. Incisions should be made parallel to this vessel to avoid injury. Accidental injury causes copious bleeding, and application of a clamp is difficult. Most hemorrhage can be controlled by a pressure pack, which is kept in place by tie-over sutures for 24-48 hours. The pack can be safely removed after 48 hours, ensuring effective control of bleeding from the greater palatine artery. Injury to the sublingual artery can occur accidentally during mandibular implant placement or while working on mandibular teeth. This may lead to a large sublingual hematoma, which can compromise the airway and become life-threatening. Most cases can be controlled by application of electrocautery, but sometimes ligation of the lingual artery or even the facial artery may be required. Expanding hematoma may necessitate tracheostomy to secure the airway. Prompt recognition and intervention are critical for patient safety. The lingual artery arises just below the facial artery and can be exposed in the submandibular triangle. A curvilinear incision is made from the gonial angle to the mental region, exposing the lower pole of the submandibular gland. The gland is lifted and the tendon of the digastric muscle is exposed. The lingual triangle formed by the digastric tendon, posterior myloioid border, and hypoglossal nerve is identified. Vertical fibers of the hyoglossus muscle are separated and the lingual artery is ligated. Control can also be achieved by ligating the artery at its origin from the external carotid artery. The facial artery is the third anterior branch of the external carotid artery and can be easily ligated where it crosses the lower border of the mandible, just anterior to the masseter muscle. The facial vein accompanies the artery and lies posterior to it. The marginal mandibular branch of the facial nerve crosses superficially over the artery and vein. To prevent nerve damage, the incision is made 1-2 cm below the lower border of the mandible. The artery is isolated, tied, and cut, ensuring effective control of facial artery bleeding. The maxillary artery is a terminal branch of the external carotid artery and is situated deep, making direct ligation difficult. The transantral approach for ligation has been described, but most bleeding can be controlled by direct pressure with packing. If packing is insufficient, ligation of the external carotid artery may be necessary. The maxillary artery is at risk during temporomandibular joint surgery, as it lies medial to the condylar neck. Proper technique and anatomical knowledge are essential for safe management. The superficial temporal artery is a terminal branch of the external carotid artery. Bleeding from the temporal region can be managed by direct identification of the bleeding point and electrocoagulation. Pulsations can be felt just anterior to the preauricular region, and the artery is often encountered during temporomandibular joint surgery. Exposure is achieved through the same incision used for joint access. Proper identification and coagulation ensure effective control of superficial temporal artery bleeding. The external carotid artery gives rise to multiple branches, including the superior thyroid, lingual, facial, occipital, posterior auricular, ascending pharyngeal, maxillary, and superficial temporal arteries. Extensive anastomosis exists across the midline, meaning unilateral ligation may not completely stop hemorrhage. The artery can be ligated just above the origin of the superior thyroid artery in the carotid triangle or higher, up in the retromandibular fossa. Proper identification and ligation are essential for controlling bleeding from branches of the external carotid artery. Ligation of the external carotid artery in the carotid triangle is performed with the patient supine, neck extended and rotated contralaterally. An incision is made at the level of the hyoid bone, and the platysma muscle and superficial fascia are cut. The sternocleidomastoid muscle is retracted, and blunt dissection exposes the carotid sheath. The external carotid artery is identified by its branching, and umbilical tape is passed and fixed superior to the superior thyroid artery. Ligatures and transfixion sutures are applied as needed to control bleeding. Ligation of the external carotid artery in the retromandibular fossa involves a planned incision behind the ramus and angle of the mandible, starting at the tip of the mastoid process and continuing below the mandibular angle. Skin and platysma muscle are incised, and the retromandibular vein, external jugular vein, and branches of the great auricular nerve are sectioned. The parotid gland is separated and retracted, exposing the posterior belly of the digastric and styloioid muscles. The mandible is pulled forward to widen the fossa, and blunt dissection exposes the external carotid artery for ligation.